Let's welcome Ed Heidig, Regional Director, to the stage. Give him a round of applause. So tell us first, Edward, what is Region 9? What are the geographic boundaries there?
Well, please call me Ed. And Region 9 includes the 4 western states, Hawaii, California, Nevada, Arizona, plus the Pacific Territories, Guam, American Samoa, and the Northern Mariana Islands, as well as 3 independent countries that have a contract with HHS until 2023 to provide healthcare services, Palau, Micronesia, and so forth. So it's a wide-ranging area, 8 time zones, and it's 10 jurisdictions.
I know the one way to frame your role is as the president's senior political appointee for healthcare in this region, in the state of California. What does that mean? What is the job of the regional director as you see it?
Well, I think the regional director is an ambassador from the administration to first the US regional staff in San Francisco and throughout the West. It's an ambassador or a liaison with the state governments as well as the territories and the Pacific Islands. It's a listener. Every good ambassador listens to folks and takes that back, and broadcasts a little bit too.
Yeah.
So it's all those things. I enjoy the leadership role in the region, to be working with the staff in a collaborative nature. I enjoy, leadership is about persuasion, and a big part of persuasion is listening.
Mm-hmm. So give us the sort of broad brushstrokes to start of the administration's, the 4 pillars of the administration's health policy platform.
Well, the most important job is addressing the opioid epidemic, which is a huge, it's the epidemic of our lifetime. You have 48,000 Americans dying each year, or this year, every year, and what is that, 161 die per day. It's a huge challenge in front of us. It's something that, this is Opioid Awareness Week, and most Americans aren't aware of the opioid epidemic. So that's one thing that we're very much interested in. Also bringing down the high cost of prescription drugs, which is too high, and they're a drag on the health sector economy. Trying to pay for value and outcomes instead of tests and procedures and CMS, and as well as making healthcare more accessible and available in the private market.
There are a lot of things that people get worked up about politically, particularly in California, a relatively blue state vis-a-vis a red administration. The opposite is also true in places like Texas vis-a-vis the old Obama administration. But it does seem like, to me at least, that the work CMS is doing to move Medicare in particular towards a more value-based payment methodology seems to have pretty strong bipartisan support. There's not a lot of tussling and arguing, and not a lot of cable news folks talking about CMS. How would you sort of speak to how that policy is taking shape? I know CMS is just one of the operational areas that you liaise with, but give us some insight into how the CMS policy machine is going, and where does that vision take us?
CMS is meeting with stakeholders and trying to find where they can reduce the time that it takes to do coding and bill processing and move it faster, remove this. I think we generate 10,000, 11,000 pages of regulations a year, and that goes on top of the underbelly that's already there. that has to be brought down. The undergrowth has to be cleared out. One of the Secretary's initiatives is reimagining HHS, trying to make it faster, quicker, more efficient, streamlined. It should be. There's a lot of work to do, and it starts with communication. I applaud what you're doing here, because to bring that space of people coming together, people of goodwill, we can work on these kinds of issues and be better. We can always be better than we are. Yeah. And all of us together are going to be better than any of us by ourselves.
So give us a little window into some of the meat around some of the four topics you mentioned that the administration's focused on.
Sure.
And I'm particularly interested in price transparency of pharmaceuticals. What can you tell us about some of the work that's happening there?
Well, one thing, generics is a huge opening for reducing the price of prescription drugs. And FDA, under the leadership of Dr. Scott Gottlieb, has really created an efficient, streamlined process to review, to review them and get them processed so that obviously they have to be safe and effective. But last year, I think FDA released 219 approved generics. And this is, if you then times that to CMS, where CMS has $21 billion of drugs, prescription, in their formulary. The generics make up maybe half of that. That's quite a savings that can be done, can be utilized. So in July of last year alone, I think there was a record number of generics that were approved. That's just one thing. The negotiation that has to go on in combination with the generics that has never been utilized in the public sector at CMS. So that would be another thing. I think a new innovation hasn't been announced yet or released, but drug facts listing, where you might have a third way of working prescriptions, where with, again, the safety and the effectiveness gold standard of FDA, you look at affected process with CMS recipients, and that would be a quicker way to get the drugs to folks in a cheaper way.
How are you? So you've been on this job a whopping 4 months, is that right?
4 months. That's yeah.
Let me ask sort of this personal question of what has been the biggest surprise so far, having been previously in state service in Sacramento, which we'll speak to in a second, but what's been the biggest surprise about moving into this federal role in the last 4 months?
There's been so many. First, I'd say how big the job is and how many different populations are affected. I think the first week I started, I had to convene what's called a nation-to-nation consultation with the Indian tribes. There's 153 Indian tribes in Region 9. And I met with many of them, and it started at 8 o'clock and it finished, the last session was 5:30. And HHS administers the Indian Health Service program, and the role of the regional director is to be there and to listen to complaints, problems, things to point with pride. And I have to say that in that conversation, I learned to listen in a much different and deeper way. I wanted to say and interject, we're going to have a new relationship. You can count on that. But an inner voice told me, hey, they've heard that every 20 years for the last 200. Yeah. Just shut up and listen. And it was probably 2 of the best days of my professional career to hear that. And I followed up with a visit to 3 of the Indian tribes in California the Urox, the Hupa, and the Curox, and front lines of the opioid crisis in California. One community I visited, a community of about 1,050. There are 1,000 prescriptions for opioids in that community, and 20 known heroin dealers as well.
Wow.
And to hear the dimensions of the community leaders sitting across the table with their community shredded and not having the social fabric that they want, that they need to put that community back together to be self-empowered, it's a gripping thing.
Yeah.
And that's it's a dimension of the job that I take seriously and soberly.
So prior to this role, one of the positions you had was as Chief Deputy at the Department of Managed Healthcare, and served in that capacity for a number of years, or at the MHC. What is that experience sort of as a regulator of health insurance in California, much of health insurance in California, how does that inform the work you're now doing at HHS?
Well, it informs it a great deal. It certainly was a fantastic introduction to the private health insurance market and the delegated model. I appreciate so much the professionals that were there and that worked with me. And I tried, and my boss, Cindy Enos, gave me support on trying to build team building, taking team building and facilitating the job environment in a way that, and emphasizing what our goals were, which is really leadership. Mm-hmm. And so that's a fantastic crossover that I've been trying, endeavoring to do. And it's something that every work group, I think most of the successful audience here have adopted those things. And government tries to imitate and catch up, but I think we're doing it. It's a very collaborative model that we have in Region 9. I'm proud of my regional administrators that I work with. They're fantastic professionals. My personal staff, Skylar Hall and Bonnie Preston, just excellent all around.
Rita, do you have your microphone handy? I don't know, or Margie? I want to grab a microphone. Your boss couldn't be here today, President Trump, but you mentioned your old boss, Cindy Enos, and I want to put her on the spot here real quick. Right up here, Margie. Cindy, who is this guy? We got a microphone coming. Why don't you just tell us about the kind of, what we all should expect from this regional director, your former chief deputy when you were the head of DMHC.
Okay, I'd be honored to talk about Ed for just a minute. But first of all, Ed Heidig has had a very long and distinguished career in state service. And to each of his assignments has brought 3 abiding characteristics that were so prominent during my close working relationship with him for 6 years, I think, at the Department of Managed Healthcare. First is just one of the strongest ethical cores that I personally have ever met. And his level of integrity is absolutely at the highest level. The second thing that he brought that was exceptionally important to me at the department was his value and respect for the inherent dignity and worth of every individual, whether they were an employee, a low-level staff person, somebody calling in to get help, any of our stakeholders. And I guess the third thing would be just his respect for deep inclusion in the stakeholder process and the engagement. And these characteristics are going to serve him well. And again, he taught me one thing that I think is really an important life lesson for everyone, which is one time I was going to take a problem to the governor and basically tell the governor, well, I can't get this done. And he said, no, no, no. He stopped me, grabbed me by the throat or something and said, no, no. And he said, no, you don't take problems to the governor. You take pretty wrapped packages. And the governor gets to untie the bow and unwrap the package, and inside is the solution. You did say that, you remember? And at any rate, that was a wonderful lesson. So, Ed, I just can't, I just have the highest regard and wish you very, very well.
Thank you so much, Cindy. Those were the best, you can see those were the best 5 years of my life. But you didn't mention my self-deprecating sense of humor. I thought that was a better laugh line, but I'll work on it.
So what is the box that you can take from California, wrapped pretty with a bow, bright blue bow, to Secretary Azar? What are the kinds of things that we can take as a community here through you to the federal government that is a little more constructive and that can move the ball forward? Because there's just so much stuff to wade through on the negative side, so many problems. Where do you see the opportunities for pretty bows?
Well, I think we could do a lot of different I don't know if they have to be blue bows, but I think we could do a lot of different projects together. I mean, these problems are so intractable. And when I went to the Indian reservations and communities and rancherias, I thought, it would be nice to have a lot of the healthcare community there, because government isn't going to solve all of the problems that are before us, or those problems. Clearly it speaks to a community psychology model with employment. And we have to break down all the silos. Not only the silos within US HHS, but the silos in government, the silos in our disciplines, are what you said in the beginning, that we all are experts at different parts of it. So I do believe in that sort of participatory democracy where we could all contribute in that mosaic. And I think Secretary Azar and his team are really honing in on what can we do, how do we get there faster, quicker, better. That's all good. And the community as well.
So Ed has allowed me to sort of call on some of you all. I do this at a dinner the night before with some wine. It's easier than it is at 8:30 in the morning when you're all still waking up. But Margie, will you run a microphone to Greg Buchert here, up right in the middle? Greg is President and CEO of Blue Shield California Care First Health Plan. Pediatric ER physician and now insurance executive. Greg, how would you categorize, as a Medi-Cal plan lead, the opportunities in the Medi-Cal space? It's a state-federal relationship. You can't do much in this future procurement that isn't blessed by CMS and the feds. But what does the federal government need to know to improve Medi-Cal here based on all of the work that the plans are doing and the state is doing? What would you say as ambassador from Medi-Cal to the federal government that these folks need to know?
Thanks, DJ. I always start squirming when I get one of these spontaneous questions. But I'd say number one is the fact that we are covering so many more individuals as a result of the Affordable Care Act, where in California it's been an overwhelming success as far as ensuring more people with the Medicaid program. I think we have a number of 1115 waivers that are in process right now with the Health Homes Project and the whole person care. So I think that concept of integrating care for individuals is probably the most important thing on a go-forward basis, is that we treat everybody as a whole person and not just a member that's part of a number of different funding streams that often fragments care. So the more we can integrate care, the better.
Are there specific things that you might point to that that a regional director could take back to CMS and say, as we renegotiate our waiver, it's not your job, it's the state's job, but as we sort of move forward down that path, keep these things in mind? Integrated care is one of them. Are there other things you want to highlight?
I'll definitely start with integrated care, anything to support the social determinants of health. I think that's one of the things that I think we're all struggling with right now as we look at the information that shows that what typically health plans pay for, doctors, hospitals, therapists, others, is just a small component of what impacts somebody's overall health status. And while we struggle with that as a health plan and as a Medicaid program, it's what role does the federal government play in addressing so many of the issues affecting so many of our members and residents of California. That would include housing, nutrition, and food safety, and other things that impact somebody's care on a day-to-day basis. And then finally, the fact that here we are in such a diverse state of how do we provide culturally competent care to the residents that we're serving?
Yeah, good. Any thoughts on any of that?
Well, yeah, I think some of the things that I touched on earlier and that you mentioned go part and parcel together. I mean, the whole idea of paying for outcomes and value as opposed to tests and procedures, the idea of freeing up physicians and providers to have more face time and less form filling out and regulation compliance work that isn't working. And culture awareness and reaching out. I mean, that's really, we understand that at the federal level. We can do better at it, but I'd like to be more supportive and listening and reach out to you and be able to meet with you and see what we can. I think DJ wants us to do work, so that's great. Let's get it on. I don't know if it's easy to do in the morning in this kind of a setting, but certainly I'd like, there's a lot for me to learn and to follow up on. I'd be happy to meet with your team as well.
I mentioned, pick on Greg a little bit, or called on Greg, didn't pick on, in part because I think one of the biggest issues that you may face during your tenure is the renegotiation of the Medi-Cal 1115 waiver, which will expire at the end of 2020. And that is not usually we're going to be right in the middle of a federal election. The California next governor will have just stood up his administration in 2019. It'll take a little time. But that 2020 window is going to be a very impactful window to renegotiate this waiver. There's not a lot of people, there are plenty of people thinking about it. There's not a lot of work happening there. That might be one of the things where you can help sort of begin to convene a conversation. That's a DHCS-led initiative, but there's a federal role to play in that waiver as well. I also want to ask Bill Barcelona, who to know him is to love him. Everyone, I think, respects and admires him. He's up front here, Margie. Even if he has beaten you in the legislative session, you still respect him, I think. Bill, can you talk about Medicare and your members at America's Physician Groups and how well some of the CMS innovation is coming? There was a big RFI out about changing payments to physicians that has a lot of stuff in it that we could talk about maybe another time, but that's very bleeding edge. And the allowance of social determinants in supplemental plans, that's very bleeding edge. What message from your members, particularly in California, would you offer to Ed and the federal government to better inform their perspective?
Sure, thanks. Okay.
And maybe just tell us a little bit about APG and who you are and all this.
Okay, so America's Physician Groups is the former CAPG, California Association of Physician Groups, and about 3.5 years ago we expanded pretty rapidly across the U.S., and I think we're in about 44 or 45 states now. We have about 310 physician organizations nationwide and about 180 in California. And California was kind of the birthplace of what we call the capitated delegated model, which is basically physician groups who take risk-based payment and assume some of the administrative functions of a health plan at a closer level to the point of healthcare service delivery. So they're responsible for credentialing physicians and for quality control, things like that. What we found in the Affordable Care Act was a tremendous interest across the whole country among other physician groups that were just organized on a fee-for-service basis as medical groups, if you will, to look at the California model and to see if it really offered advantages for physicians, for care delivery options, and I think the rapid uptake of our membership kind of proves that there's a lot of value in what we do in California. With respect to the federal government, what we've observed over the past few years is tremendous interest by CMS and HHS in this model in California, this collaboration between health plans and organized physician groups. And it's led to increased discussions with Secretary Azar and his staff and the CMS staff. And you mentioned the two key areas. The rollout of MACRA has been difficult for a lot of what I'll call line physicians, physicians who are delivering care to Medicare patients on a daily basis. What APG has tried to do is to help those physicians organize out of the MIPS portion of MACRA and into the APM portion, the advanced model. We're having some success, but it is complicated. And I think the takeaway there is that in these complicated transitions away from pure fee-for-service, we need as much back and forth education as possible so that providers know what the regulators are thinking and regulators understand how the providers operate so that they can understand exactly what levels of risk can be assumed by certain provider organizations. I hope that resonates a bit. You can't have enough back and forth communication to make these things work. It's a heavy lift, and it's a worthy goal. Moving the provider system off of pure fee-for-service to value-based payment will benefit everybody, especially patients in the long run, because it makes everyone more accountable. Second point that you raised, DJ, is this great new transition to the incorporation of social determinants of health in Medicare Advantage. And Medicare Advantage has taken off in the last few years. There was a time 5-6 years ago when the average age-in rate for Medicare only produced about 10% enrollment into Medicare Advantage, and 90% of the enrollees who aged in at age 65 went to traditional Medicare. And now it's jumped to over 51% on an annual basis. Boomers are voting with their feet for this kind of integrated, coordinated model. And California is really one of the highest performing states in MA. And now with CMS moving toward the integration of social determinants of health, I think we can all deliver far better care to seniors outside of the 7 duals demonstration counties. We can do this across California, find innovative ways to do this. And I think Medicare Advantage is the finest expression of how payers and plans and providers can align themselves to produce superior outcomes for patients. I think the data supports it time and time again, and especially in California, but even across the country, we see great pockets of innovation and high performance. So please come see our groups, Ed, and let's talk more. But I think these areas hold a lot of promise for improvement in the healthcare system.
Thanks, Bill.
Okay.
I will, Bill, and I would look forward to it, and I appreciate your remarks. I think they're well chosen.
Do you hear much from physicians in your capacity? I know you're new in that position and you have a lot of opportunity to get out, but Bill mentions that MACRA has been a grind for some physician groups. Are you hearing about that in your position?
I'd like to hang with you for the rest of the day, but I am actually going out to meet with some physician groups. But I haven't to date. I apologize for that, but there's been so much there's so much to get my arms around that I haven't had a chance to go out.
4
as
months
much,
is,
but,
is a short tenure so
Yeah.
far. Do you, let me also preface this question by saying I recognize, again, 4 months is a short tenure. But do you get a sense when you correspond among your other regional directors that in some way the successes of Medicare Advantage in California can be promoted to other regions that have less uptake that might still be in traditional Medicare? Do you see yourself in some ways, or can you play a role as ambassador from Medicare Advantage to the rest of the traditional Medicare regions?
We're always sharing best practices. Just on going back to the opioid, the state of Arizona has red caps that they've mandated to be put on prescription opioid bottles. And that's just such a easy one. And those kinds of ideas should be shared and passed on. So certainly the ability to put patients first, that's one of our mantras under Secretary Azar. Put patients first, and put patients before paperwork. I mean, don't we want that? And how can we make the system and the underbrush that we've inherited change and become much better trimmed so that we can allow these kinds of initiatives to take hold and to grow and to expand? We can do a better job. We want to do that better job.
So people have opinions about the president, and we're not going to change those here today, but there are another couple 100,000 people that work in the federal government that are doing the work of the federal government. Clearly you have some relationships in this room and in California. How does this community help you do a good job on behalf of this state?
Well, I think I'm not afraid of the truth, so it's always better to have honest dialogue. I'm also in many, I need more input, I need more information. So the spending the time, having the conversations, meeting with these situations, particularly as they affect our four priorities, because we want to get to the finish line on those, it's all good. Mm-hmm. But if there's a problem, I need to know about it. It's a big area, but I'd like to do the very best that I can.
And what's the best way for people to communicate with you about, constructive boxes with bows on them?
The regional office, and to email me. I'm on the regional office. I have my line posted, and I think, isn't it in the? I'll give it to you. And if anyone has trouble reaching me, and you're in Sacramento on a Saturday afternoon, give me a call, and come over, and we'll have a barbecue at my house. So,
good.
Yeah.
Good. You heard it here first. You can barbecue at the regional director's house.
Yeah.
What counsel or advice would you give this group about how they should navigate this time of transition and political, challenge, polarization? What should they be oriented? Which North Star set of principles should they be oriented towards as they try to lead their organizations?
Well, I think I really appreciate what you do for a living. I appreciate what your members are doing. Those are on the front lines of providing healthcare services to folks under the principles that you elucidated earlier. And I think that there's much more commonality on this kind of work. It's so complicated. There's so much to do. And if there's things that the federal government is in the way on, I'd like to know so I can communicate that up.
Good.
Yeah.
Are you going to stick around here for a few minutes?
I will. Good.
Ed Heidig, the Regional Director for US Department of Human Services, Region 9. Thank you, sir, for making time.
Thank you.
Let's give him a round of applause.
Okay.
Good.